Hello everyone, so today we are talking about Nancy's NIV. Okay, so this is another video in Think Like a Medical Registrar series. My name is Dr. Vishal Kumar. I am the founder of Keen Medic, the channel and also the site where you can find my many resources. So in this video we're going to be giving you a scenario for you to consider about whether or not you should be giving NIV in this specific patient. Okay, NIV or not NIV is the question, my friend. Next, we will be talking about the BTS Guidelines, British Thoracic Society, about NIV, okay? And these will be the latest guidelines, and I will provide the resource in the description below along with the other resources, so you can check them out. And specific considerations for non-invasive ventilation itself. And lastly, monitoring for someone who is on NIV, followed by a quick summary. Before I start, I'm just going to give you a quick explanation of what NIV is. Okay, so NIV stands for non-invasive ventilation, for those of you who are not familiar with this. And it is also known as BiPAP, okay, B-I-P-A-P, okay. So it's basically a way to ventilate a patient who is in decompensated respiratory failure for whatever reason, for whatever underlying reason, okay, with the aim of improving respiratory acidosis. Okay, that's essentially what it does. So let's start off with the scenario then. So Nancy, a 76-year-old lady, has just been brought into A&E, resus, and you are seeing her as the medical registrar on call. Okay, good times. She is known to have COPD, AF, atrial fibrillation, okay, ischemic heart disease, and walks with a Zimmer frame indoors in her own house. She has TDS package of care, 3 times a day package of care. Okay, these are all abbreviations that we use here in the UK. If you're not familiar with this, make sure you familiarize. I've deliberately written them here so that you are becoming more familiar with them. Okay, and uses a number of inhalers at home. Okay. She has been increasingly short of breath for the past 4 days and was treated for chest infection by her GP the week before. This morning, her carers found her to be in bed and extremely drowsy and not responsive. So they called the ambulance. So she's been brought into A&E resus. Okay, A&E have given you a summary of the observations and treatments so far that they have done. Okay, so let's have a look then at the observations. So these are the observations. Temperature is 37.2, heart rate is 117 per minute, and it's regular. Blood pressure is fine, 128/76. Respiratory rate is 32, and her saturations on air were 82%, which improved to 89% on 35% of oxygen via the Venturi mask. Okay, I haven't written it here, but it's via the Venturi mask, because if it is, say, through a nasal cannula, you can't tell how much percentage wise you're giving oxygen. Okay, so it's via Venturi. So that's what we have. Okay, so let's have a look at the treatment then. What have they done? So they've given her back-to-back nebulizers, salbutamol and ipratropium. Okay, good. Hydrocortisone, because she's very tachypneic and not really swallowing anything. So they've given her IV hydrocortisone, which is fine. She could have had prednisolone orally if she was a bit better, perhaps. And also, she has been given IV comoxiclav, 1.2 gram stat. So she's given broad-spectrum antibiotics, some steroids, and nebulizers. Okay, so all good, I think, all right? So it looks like they have treated her for infective exacerbation of COPD. All right, okay. So let's look at her arterial blood gases then. So on arrival, this was her arterial blood gas. Okay, so I'll read it out and then pause the video and have a look at it yourself and interpret it yourself, okay? So pH of 7.26, PO2 of 7.6, so this was on air, okay? And PCO2 of 8.6, bicarb of 32, and lactate of 2.6. Okay, so that was on arrival. 1 hour after treatment, so this was the treatment that she got, and after her treatment, this was the blood gas. pH of 7.27, PO2 of 7.9, PCO2 of 7.6, bicarb of 33, and lactate of 2. So, what are we thinking here? What do we think the patient actually has got? And does she have infective exacerbation of COPD? Maybe she does. I don't know. You are the medical registrar, so you need to think about this. So, the question is, NIV or not to NIV? Well, we'll come back to this later because we need to talk about this properly, don't we? So, here are the BTS guidelines, British Thoracic Society, and this is what these are the guidelines followed by the entire country, all of the UK, and the local protocols are based around the BTS guidelines. Okay, so you do need to familiarize yourself. This is a summary of the guidelines, which will be linked in the description below. So this link I will put it down under the description under the video, and what you will need to do is when you're at this link on their website, just scroll down and find NIV, and you will be able to access this document, and you will be able to find this summary. Okay, so let's have a look at the indications for COPD. So these are the magic figures that you need to remember as the medical reg on call. Okay, so pH of 7.35, PCO2 of 6.5. Now bear in mind, these are figures for someone who has had medical therapy, optimal medical therapy. Okay, so optimal medical therapy would be back-to-back nebulizers, controlled oxygen therapy via Venturi mask, steroids, antibiotics, all of this. Okay, so that's what optimal medical therapy is defined as. So this is not the on arrival or initial blood gas. Okay, so respiratory rate of 23 is also part of the guidelines. However, if someone had a blood gas of pH of, let's say, 7.26 or PCO2 of 7.5, you wouldn't just leave them on normal oxygen therapy without NIV if it is appropriate, because while respiratory rate is included, anyone who has such a blood gas would not have a respiratory rate of, say, 9, 10, 11, 12, a normal respiratory rate basically. Okay, or depressed unless they have been given some kind of respiratory depressant, in which case again you should be thinking about whether this is like a opiate toxicity type picture, but we're not talking about that right now. So let's get back to COPD. So for COPD purposes, these are the numbers that you need to know about. Okay, so make sure you know them. If persisting after bronchodilator therapies and also controlled oxygen therapy, as I said earlier. Okay, so with any treatment, any medication, any fluids, any ventilation, you need to be thinking about any contraindications. Okay, so for the purposes of NIV, there really aren't many at all. So these are the absolute contraindications which you really won't find much of in real day-to-day practice. Okay, so these are facial deformities. You can't put a mask which is blowing in and out air on a patient's face if they've got a facial deformity. So it can basically, it's all about the mask fitting well. Okay, so if the mask does not fit well and provide an adequate seal around the face, around the airways, then it's not going to work. That's why facial deformity is a contraindication. Similarly, facial burns, so you can't be using a ventilatory device with positive pressure on someone with facial burns, because that's only going to worsen it. And again, it won't provide an adequate seal. And also, if someone has got a fixed upper airway obstruction. Now, this is the realm of the ITU team and also the ENT team. If they have got a fixed upper airway obstruction for whatever reason, whether that's some malignant cause, mucus, some infection, epiglottitis, whatever, then you wouldn't be using this. Again, this is something that you really don't see much of. I have never seen patients with any of these in my years of clinical practice, and these contraindications have not come up at all. Okay, but just be aware of them anyway, because you might be asked about them in your day-to-day practice and also your PACES exam, of course. Okay, so with NIV, there are some specific things that you need to consider for every single patient. This is first and foremost the functional baseline of the patient that you are considering NIV for. Okay, so functional baseline. Functional baseline basically means what you are able to do on a day-to-day basis for yourself. Okay, can you look after yourself or do you need help? So that's what it essentially is. Okay, so to quantify it, to put patients on a scale, what you can use is something called the Rockwood Frailty Score. You can Google this. This is easily available. This is part of many trust protocols when patients are being clocked in, etc., etc. So this is something that will allow you to grade patients in terms of frailty and independence, and allow you to consider whether or not NIV is appropriate. If it is not available, or you can't remember it, etc., then what you can do is just think about whether the patient is fully independent, dependent, frail, or whether they're end of life. Okay, so it's just a very simple, easy way of grading it. So it's like your GCS and your AFPU scale, okay, for grading consciousness. So this is like your GCS scale, and this is like your AFPU scale, basically. So you need to think about functional baseline, and it is absolutely crucial because for patients on NIV, basically they have become so unwell that they are needing ventilatory support, right? So you need to think about how far you are going to go with the ventilatory support, whether NIV is going to be as far as you go, or they should be a candidate for intubation and ventilation. And of course, you're not going to do that, okay? You are going to ask the ITU team to do that. So which is why you need to think about the ceiling of care and whether NIV is even appropriate in that patient. So for example, if a patient has got terminal cancer, they are dependent on care for everything, and they have got dementia on top of that, and they are pulling away even the nasal cannula, they are not tolerating it at all, they are extremely agitated, and then you need to think about whether the NIV is even appropriate. Okay, you need to talk to the next of kin of the patient or whoever may have lasting power of attorney, and think about just keeping them comfortable, because they may not even tolerate NIV, and there's no point putting the patient through that level of distress when they are not even tolerating a simple nasal cannula. Okay, if they can't tolerate a nasal cannula, they're not going to tolerate NIV. It's quite simple, really, right? So if NIV is appropriate, you need to think about whether ITU level care is appropriate. This is something you need to think about for every single patient. If ITU level is not appropriate because they are frail, end of life, dependent, whatever that may be, whatever the reasons, then you would need to think about putting in a do not attempt resuscitation form following discussion with the patient and the family, and also writing clearly in the notes that ITU is not appropriate and that NIV is the ceiling of care. Okay, guys, this is very important. As the medical registrar, you will need to take these decisions before you even put patients on NIV, or whilst NIV is being considered or arranged, okay? Because if a patient deteriorates, then it is on you to resuscitate them. And basically, you should be aware about it from a PACES point of view, because patients may well come in completely well, but you may have a COPD scenario, and this discussion may follow with your examiners, okay? They are very much in their right to hand you a blood gas and ask you about NIV and also ceiling of treatment. So setting up the machine is something that, from a practical point of view, that you may have to do. You won't have to do it in the PACES exam. Find out who does this in your hospital when you're working, when you start working. This may well be yourself. You might have to set up the NIV machine, in which case familiarize yourself with how to do it. It may be the outreach nurse or the respiratory team. It can be any of these people, okay? But you should always know how to set up and operate your NIV machine in your hospital. In terms of monitoring, local protocols should always be followed. So local protocols are largely based around the BTS guidelines anyway, but every hospital has a protocol and NIV pathway, okay? So those should be followed. SATS targets should always be 88 to 92% in patients who go on NIV due to COPD, okay? Generally, they should have arterial blood gases for monitoring, and these should be performed at 0 hours. 0 hours is when you do the blood gas, which leads to NIV being set up, okay, being commenced. And then 1 hour after NIV is commenced, 4 hours after NIV is commenced. This is in red because this often is the time frame, the target where you would be thinking about prognostication, okay? This is the time where you think about, okay, is the patient responding to NIV or not? Because if they are not responding to NIV, then you may need to think about whether it's even worth continuing with NIV and just keeping them comfortable, okay? Or you might need to think about escalating to ITU if they are appropriate for ITU. So this is why this is the target that a lot of hospitals will be using for prognostication purposes. And the 12-hour one, just to make sure that they are still responding and that, you know, NIV settings don't need to be changed. So I haven't talked about NIV settings on this occasion because for PACES purposes, it's not quite relevant. I will be happy to do it in another video if you want me to. Make sure you tell me in the comments below if you want me to talk about NIV specifically and the settings, okay? Alright, so let's get back to Nancy then. Remember Nancy? We talked about her right at the start. So should Nancy go on NIV? Nancy, let's remind ourselves, is a 76-year-old lady with COPD. She walks with a Zimmer frame and has three times daily package of care. And her blood gas at 1 hour was this. Just pause the video if you want to remind yourself. So the answer is yes, she should go on NIV, okay? But the question is, whilst she should go on NIV, remember what I said about ceiling of care. You should be thinking about ceiling of care. How far are you going to go? But you know, I don't think that she is a candidate for ITU, really. So what you should be doing is that you should be talking to the patient and the family regarding DNA CPR, not resuscitating, and also making it very clear that NIV is the ceiling of care. Why am I saying that she's not a candidate for ITU? Because of this, okay? So she walks with the Zimmer frame, so that tells you that she's not up and mobile independently. She's not going to the shop, she's not driving a car, she's not doing any of that, okay? She has got TDS package of care, so there are carers, people coming in to look after her, so she's not well enough to be looking after herself. That tells you that she's got a poor functional, poor physiological baseline, so she's not really a candidate for ITU. Okay, so that's how I assess that she's not a candidate for ITU. But if you're not sure, okay, for any patient that you're not sure about, you're well in your right to say that you would get ITU team to assess the patient or get your medical consultant's advice on whether the patient should go to ITU. Because ultimately, the medical consultant on call is the responsible clinician for the patient. So we've covered loads, guys, today. So I hope that makes sense. Let's do a quick summary then. You need to be familiar with the BTS guidelines for NIV, okay? Make sure you check out the link in the description below. Functional baseline and ceiling of treatment are vital for patients going on NIV if you're considering it. And find out local protocols. Every single hospital in the UK has got their own NIV protocols. Use them and also monitor appropriately with arterial blood gases. Make sure that the SATs target are set to 88 to 92%. So if you are a keen learner, if you are motivated, make sure that you check out my book, which is available in the Kindle and paperback forms, on strategies for high achievers for PACES, and also my course, which will be undergoing reviews in the months to come. I hope that was useful, guys. I will see you in the next video.